Okay, thank you, Alex. I'm Steve Raman from UCLA. I'm a professor of radiology and also in the departments of urology and surgery. I'm director of prostate MR imaging and integrated diagnostics program here. And I'd like to talk to you about how MRI and PET scans have revolutionized diagnosis of prostate cancer in 2024. No relevant disclosures. So we're going to talk about prostate cancer, limitations of current techniques, including the PSA, DRE, and in the transrectal ultrasound or TRUS biopsy. We're talking about sharks and minnows because that's a theme that's going to recur throughout the talk. And then we're going to talk about MR imaging techniques for diagnosing and staging and really talking about prostate cancer in its entirety and understanding how MRIs become critical for prostate cancer biopsies and other sampling of prostate cancer, and how MRI improves all aspects of prostate cancer treatment, how other things like artificial intelligence improve prostate cancer diagnosis, and how MRI and PET scans predict worse prostate cancer biology, all the bad genes and bad proteins and everything else that is tied up with prostate cancer. As you know, prostate cancer in 2024 has around 300,000 new cases with 35,000 deaths. That's in the United States per the American Cancer Society. 15% of men will be diagnosed with prostate cancer in their lifetime. Now, prostate cancer is a matter of minnows and sharks. So 14% of all men diagnosed with prostate cancer will progress to metastases. And this is what we want to diagnose. Who are these people who are going to go on and have bad prostate cancer? Half of men will have low-risk prostate cancer without progression. Who are those people? Those are the minnows. Well, how are we going to diagnose those and not do anything to impact their quality of life? The problem is that most men to date were overtreated with lots of side effects, which are really terrible. So we don't really want to do that. Prostate cancer in reality is a range of diseases. We need to pick out the minnows and sharks. We have lots of existing ways to do that, and they're all pretty good, but they're not necessarily good enough to do this as they were. They include prostate-specific antigen, digital rectal exam, systematic transrectal biopsy. They were significant advances for their time, but I think in 2024, we can do better than this. The prostate-specific antigen was introduced in 1987, and these are some of the old papers from that time, the original paper, and you know, it has really pretty much revolutionized how prostate cancer is thought of. The test picks out about 80% of prostate cancer, but when it's elevated, only 36% of men will have prostate cancer. So just because you have an elevated PSA doesn't mean a lot. Most of these men will not have prostate cancer, but it creates lots of anxiety. There's a number, PSA greater than 4. You'll hear that number. 15% of men with prostate cancer have a PSA less than 4, and 70% of men with a PSA greater than 4 will never develop prostate cancer. So that's with PSA. It's a good test, but it creates a lot of anxiety and it creates lots of false alarms. There's other ways to look at the PSA, and we won't talk about that here, but the density and the velocity and the free PSA. The density is important for MRI because the more dense the number is, and if the number is 0.015, if the density is higher than that, there's a higher chance that something will be seen on an MRI, and it may be more relevant. The good thing is, with those existing techniques, the rates of prostate cancer deaths were decreased quite a bit between 1992 and around 2010. So that was a dramatic decrease in prostate cancer deaths. So that's good. But more than 1 or 2 to 2 million men have undergone surgery, radiation, or both, somewhere in the neighborhood of 1 to 2 million men who probably didn't need it. And this is the sharks and minnows. How can we not treat every cancer like a shark? We want to pick out the sharks and from the minnows. So we just really want to minimize that problem. This came to attention even 20 years ago in this trial from Scandinavia, where they showed that whether you observed prostate cancer or you did radical prostatectomy, the probability of any problem was very, very much similar. The difference was the men who underwent radical prostatectomy had a lot of side effects. So it showed that, for the most part, prostate cancer is a diagnosis that can be watched, but we got to pick out the sharks. This is also seen in the PIVOT trial 10 years later, where death was similar between radical prostatectomy and observation. So men who underwent active surveillance and men who underwent radical prostatectomy, the risk was slightly reduced with radical prostatectomy, but those patients had a lot more side effects. Again, picking up the sharks from the minnows. The minnows can be watched. The sharks probably need some treatment, and that's who we want to pick out and go for. Again, the most recent version of this is the PROTECT trial, and that also showed pretty equivalent survival over 15 years and also metastasis-free survival. In other words, the people who underwent prostatectomy or radiotherapy had slightly better metastasis-free survival over 15 years, but not by much. So the majority of them were minnows, but the sharks, if they were treated, did better. So we got to pick out the sharks. And these three major trials have shown us that. So a diagnosis of prostate cancer doesn't automatically mean a terrible outcome. In fact, for the most part, it's a pretty good outcome. We just got to pick out the bad actors and find ways to do that. So that's our minnows and sharks. We want to pick out the sharks from all the minnows around it. Shark from minnow. The digital rectal exam, that's a tried and true method. It picks out about half of prostate cancer. When you find a nodule, about 6 in 10 times, that's a real finding, and that may be prostate cancer. But the other 4 times, it's not. So just because you have a finding, only about 1 in 5 times will it be actual prostate cancer. And if it's negative, doesn't mean you don't have prostate cancer. So it's an okay test, not a great test. And the biggest problem with it is, you have maybe Dr. Moyad or someone else doing it, and you could get every single prostate cancer, and someone else like me doing it, and you may not get any prostate cancer. So that brings us to the other thing that was actually quite revolutionary for its day, which is a transrectal ultrasound-guided biopsy. That's another mainstay of prostate cancer diagnosis. This is the gold standard for many, many years, since 1986 or the mid-'80s. And its rate of diagnosis for a first biopsy, depending on who did it, was anywhere from 40 to 70%. But it's a little strange because it's one of the only cancers that doesn't have an imaging diagnosis. You take these samples from the prostate, from both sides of the prostate, 6 to 12 samples, maybe more. And, you hit the cancer, you may not hit the cancer. But the bottom line is about half of men will have a true risk assessment of the cancer risk. So it's not great. It's better than what there was, but it's not great. It has a lot of room for improvement. The other thing is, first time, it was about 40% for diagnosis of prostate cancer, 40 to 70%. If that came back negative and the PSA kept going up, they did another biopsy, and that was only 20% successful. And then it went up again, and it had a third biopsy, and that was only 8% successful for finding prostate cancer. So it was really finding, where is the cancer? That's the other problem. It's sharks and minnows, but where are the sharks and where are the minnows? And also, it's a problem of who does it, how good they are at doing it, and where they do it. So in the prostate, you have different areas, the apex, the mid-gland, and the base. And the localization matters because the biopsies are better at the base and not as good at the apex, and that's a recognized problem. So there's all these issues with it that need to be better. So this is what a transrectal ultrasound biopsy looks like. This is the probe in the rectum, and this is when this white line is when you shoot the biopsy into the prostate, which is this kind of gray blob. You don't really see a tumor most of the time. You're just kind of shooting, and you're shooting into the different areas. You can get 6, 12, or more biopsies. Sometimes you can see the tumor. If you're good at it, you'll see the tumors. Sometimes they're bright, sometimes they're dark, but most of the time you don't see anything. So really, it's the idea of sharks and minnows, finding the shark from all these minnows, and the question is, do you even need all these biopsies? You want to find the shark and really avoid all these minnows, because that's what we want to do. The one shark or three sharks in this case from all this kind of background that we don't really need to know. And one way we do this is take lots of biopsy samples. But what if we could just go to the cancer? That's what we really want to do, and that's what we want to do, because that's what gives us the true answer about what your individual risk of a prostate cancer is. Some people have done this. This is a saturation biopsy, and this looks kind of horrible. 128 biopsies with these grids to get every little part of the prostate. Well, that's one way to do it, but that seems like it's kind of a brute force method. So the reason biopsies are not liked is because they can cause pain in a lot of cases. They can have bleeding into the urinary tract, in the stool, and in the sperm. They can have infection, and infection in the blood, and infection in the urine. So there's lots of things that are not desirable about prostate cancer, prostate biopsies in general, and prostate biopsies. Nobody likes them. Prostate cancer is the only major solid organ malignancy that's not routinely imaged. So these are, from all the old guidelines, did not routinely image prostate cancer. It's kind of strange. It's so common, but it's not routinely imaged. Dr. Walsh, who pioneered radical prostatectomy, said the discovery that would have the greatest impact in our field would be the development of accurate imaging of the tumor within the prostate. So this was in 2008. And since then, I think we found that tool, and that's MRI. We've said, and many organizations have said, prostate cancer care is blind. And this was, from in the last 10 years. This has been a recurrent theme, that we do this because we didn't have a good way to figure out where the cancers were. What we want to find is the sharks, and that's called clinically significant prostate cancer. And there's many definitions. Some of them are a tumor, but they go by tumor volume, or they go by the Gleason grade on the slide. So Gleason grade of 7 or higher, or tumor volume of 0.5 centimeters or more, cubic centimeters. But there's other definitions of this. Now, magnetic resonance imaging is a technique that uses strong magnets that affect the hydrogen molecules in your body, both in the water and fat molecules. And these strong magnets help us see the cancers and other things better, because the cancer molecules are affected by the magnets in a different way than are the normal tissues. So we can see normal tissues that get affected one way, and the hydrogen ions in the magnetic field that get affected in a different way. The exam can be as little as 10 minutes or as much as 30 minutes or even longer. So depending on what kind of exam you do, what they're doing, we can do it in a closed bore magnet, which most of the magnets are, or sometimes in an open bore magnet. These aren't quite as good, but for claustrophobic patients, they can, they do better with this. It's better than nothing for sure. So with MRI, you have different sequences. One is a T2, it's very important. One is a diffusion sequence, very important. These are different ways to perturb the hydrogen ions in your body. There's perfusion, where we inject dye into the body, and the cancers generally take up the dye, so we can see it. So on the T2, the cancers are dark. On diffusion, and this is the ADC map of the diffusion, they're dark. On perfusion, they're bright. Then we can also do with this, we can combine this with PET scans, have MRI PET scans, and the cancers are bright on the PET scan. We can use it for a variety of techniques to biopsy the actual cancer, biopsy the shark. And then we can also treat the shark with MR therapy. So MRI, magnetic resonance imaging, has evolved over the past 15 years and is currently considered the best imaging modality to grade, stage, and detect prostate cancer. It helps target biopsy of the most aggressive target, or the sharks, and helps separate the minnows from the sharks. Prostate MRI looks like this. Most of the prostate gland is bright on this T2-weighted image. There are different zones of the prostate. This is the peripheral zone here. This is the transition zone here, the central zone here. and so on. So we look at the prostate and we look at all its different components on the MRI. We know where the urethra is, where the urine comes out. It's right there. And this was done with an endorectal coil, which we don't use anymore. But this is a beautiful image of the prostate and all of its different zones. When we do all these things together, we call it multi-parametric MR of the prostate. We use a T2 weighted sequence to show us the cancer here. It's dark. Then we use a diffusion sequence where it's bright here. And then the ADC map of the diffusion sequence where it's dark. So dark, bright, dark. And then we give dye, and that's bright. And we can see how the dye in the cancer shoots up and then comes back down. And this is what we want to see, these four things, to call it confidently a prostate cancer. And we also have a way to now categorize these with a PI-RADS score. I'll come to that in a second. The same thing can be done now with PSMA scans. This is an agent that binds to a protein on the prostate cancer membrane. It also does other things, but primarily for prostate cancer, it lights up as bright on most prostate cancers. So dark on T2, bright on PSMA. Dark on T2, bright on PSMA. Dark on T2 and bright on diffusion. So all these three things together help us better diagnose the sharks and the sharks here from everything else. So on the MRI, we have different looks to prostate cancers. The cancers generally are oval or lobulated. Prostatitis and other things tend to be wedge-shaped. So we can kind of tell just from the look of it, this is not probably going to be a cancer, and this is going to be the cancer. So we can tell the sharks from the minnows again there. There are other shapes we can find. The oval is bad. The teardrop shapes are generally bad. The irregular spiculateds are bad. This what we call lenticular is bad. So we can tell just from the shapes things that are bad and things that are good in the different zones. We can know from the diffusion weighted imaging that the worse the diffusion is, that is, the brighter it is and the darker it is, the worse the Gleason score is going to be on the biopsy. So this is a non-invasive way to tell where the cancer is, where the sharks are, what kind of a cancer it's probably going to be, and how dangerous a cancer it's probably going to be. So the darker it is, and the darker it is on ADC and the brighter it is on diffusion, the worse the cancer is. So it correlates directly with the Gleason score. So the lower the ADC, the worse the cancer is by Gleason score. So this is a powerful tool without a biopsy that tells us, do the biopsy here, and this is probably going to be where the sharks are. So based on this, we, more than 15 years ago, printed this paper, and this paper showed us a way to understand the prostate MRI, and we came up with a score. This was the UCLA score, and this was showing us where the cancers were in the prostate gland, and we wanted to target the most aggressive cancers or the sharks and see how that compares to all these other biopsies that didn't target anything or potentially target the minnows. So we wanted to target the sharks. And based on that, we came up with this 5-point score that then was adopted by our section at UCLA in 2010. And then in 2012, the ESUR published MRI guidelines called the PI-RADS score. And that is now a standard way of communicating across the world what an MRI looks like. So we not only have a way to detect the sharks, we also have a way to communicate with other doctors about what we're finding so that we're all on the same page as much as possible. So we helped develop this scoring system that's now adopted, and now it's just a standard overall. So MRI is a great advance, and PET is even a better advance to add on to MRI. So basically, we say that we have a PI-RADS score lesion of 3 to 5. It's a 5-point scale. 1 and 2, we don't consider cancers, or the chances of a cancer are very low. 3, 4, and 5 are much higher chances of cancer. So we find that, we can biopsy it, we can target it with treatment, or go to active surveillance, and then we do follow-up. So we do all these things together, and this is a much better way of understanding prostate cancer. We understand from the MRI and the PET scan the biology of the prostate cancer and find the sharks. So MR-guided biopsy. So there's many ways, many different tools under MRI guidance or fusion guidance. There are lots of different tools to basically find the shark. So here's the tumor. This person had 2 different biopsies. When they came from the rectum, they biopsied this area here and this area here. The cancer was up here. They found no cancer. The PSA kept going up. They found no cancer in the 2 different biopsies. That's 24 different samples. Patient bled every time, had pain every time, and hated that biopsy. And we convinced him to do this biopsy 10 years ago. Found the cancer. This is a PI-RADS 5, UCLA score 5. It's dark on the T2, bright on diffusion, dark on the ADC, and enhances very avidly after we give dye. So there we go. We just target the tumor, find the sharks. And we can do that by different methods. We can do that here in this situation, in this circumstance, where we find this tumor by ultrasound guidance or ultrasound fusion guidance. Or in that same case, we came in with MRI guidance. And to me, if this is me or my brother or my dad, I would want this. This is like you put the probe right where it is, where the tumor is, find where the shark is, look at it in different projections, and put a needle right through it. Needle right through it. 1 or 2 or 3 needles, and this came back. All 5 of the samples we took were Gleason 3+4. So again, we went right to where the action was, and the patient can then make a decision about what to do. So, there are other things we can do looking at this, but we can now very confidently understand where the sharks are. So again, this is what we want to do. Find the sharks. This is a couple of other things that I did recently. I've since used MRI. This was a patient had 2 different biopsies. A former colleague of mine, 2 different biopsies, didn't really find a cancer here, even though we had this dark area here, slightly bright here. We ended up doing a PSMA scan, made it bright there too. And so because he had a problem with his rectum, he had another problem, but we couldn't use transrectal guidance. We just put a probe right in his perineum, where we just below his scrotum, between the scrotum and the anus. We just put a probe in the perineum, and then used fusion to find where this thing is, where the PET scan is positive, and put a needle right through it. Boom. And this was a Gleason 3+4 as well. So you can do a lot of innovative things with new innovations. You can combine them to find the actual shark. So then we said, well, why are we doing all these other biopsies? So myself and some of my students and my lab partners looked at where are all the cancers that are positive outside of what we see that are targeted. So how many biopsies do we actually need to do? And so on the cover of this major journal, European Urology, this was last year, last year, we had this paper which showed that all of the clinically significant cancer that is on any biopsy sample, in other words, these are the biopsy samples from the sharks, but what about the other biopsies? So when we looked at this, we found that almost all of the clinically significant cancers that we could find on a biopsy were within 1 centimeter to 1.5 centimeters of the original shark target. So to me, I'm not sure why we're doing these other biopsies on the other side when almost 97 to 98% of the time, there are no significant sharks on the other side. It's all where the PET and the MRI show the tumor to be. So 90% of significant core biopsies within 2 centimeters of this target. So we've gone back and said, how do we do biopsy better? Find the shark, but do less biopsies. Because if we do less biopsies, it's better for patients, less pain, less bleeding, less other problems. And so we put this together in a biopsy report that has the pathology, the MRI, the PET scan, and everything else together. This is our integrated biopsy report, and we've had this out for about 10 years. Shows all of the biology of the tumor. So MRI predicts aggressive prostate cancer. And all these papers that we wrote show that issue. So when we do these biopsies, we find the sharks, and we find that based on our UCLA score or the PI-RADS score, the higher the score is, a score of 4 and 5, we're finding cancer in the majority of them, but also they're red cancers, the more aggressive shark-like cancers. They're not in the 1s and 2s. They're in the 3s, a little bit, 4s and 5s for the most part. So this is what we're going after, finding those sharks. So we've shown, carefully looking at sections after radical prostatectomy in multiple papers, that we can find the most aggressive cancers, dark here, bright here, dark here, on the T2, diffusion, and ADC map. And we can find all of these different cancers, but the sharks are here, and we can find those shark-like cancers or the clinically significant cancers up to 90% of the time. So that's what all these papers are showing. We can find the sharks up to 90% of the time. Now, this is also now, these original studies that we did with the biopsy have been shown in 2 different randomized clinical trials, randomized controlled clinical trials, that this does better. In this, the PROMISE trial with 740 men, they showed that the MRI positive cancers, 91% had clinically significant cancer. So that's the ones that you want to possibly act on. Whereas if you just did the old way, half of them had clinically significant cancer. And I bet if you go back and look at this data on both these 2 trials, it's the Precision and the PROMISE trial. If you go back and looked at where the clinically significant cancers were, they were going to be within 1 to 2 centimeters of the target, meaning you probably don't need to take all those other biopsies. But this has been a now validated concept that the MRI targets make a big difference. With PSMA scans, you do slightly better. We said before, we can find these bright areas that correspond to the MR. Sometimes we find other areas too. So what we do is we can say that with MRI alone, we detect somewhere between 80 to 90% of cancers. With PSMA alone, we detect somewhere between 80 to 90% of cancers. But with both together, we detect even more together. So they're better together with MRI and PSMA in terms of finding those sharks or the clinically significant cancers. So with this, doctors have recognized that there are lots of ways to use all these tools. Detection of the cancer, that's the most important thing. Where is the cancer when the PSA is high? Surgical planning, active surveillance, radiotherapy planning, and so many others that I haven't even listed on here. So these are all different ways to deploy these new techniques to make the diagnosis better in every single way. So we want to use potentially active surveillance for the Minnows for patients in low volume, low grade disease. MRI, doesn't show those cancers all that well. So you're okay. You're saying that, well, if you don't see something on an MR, it's really unlikely you're going to have a clinically significant cancer. If you don't see something on MRI and a PSMA scan, very low likelihood, less than 10% chance, you're missing something big. So we've shown that MRI improves active surveillance. Just even if you're looking at the Minnows, you're following those up, MRI improves active surveillance. And we have shown that, and other people have shown that, for example, in this situation, this was when we first started using it. This is an MRI with somebody with high PSA. There was really nothing we saw, but then the PSA kept going up. Biopsies were negative. A year later, another MRI showed some darkness here, and then some other areas, and then the same area had some abnormalities on the diffusion and perfusion, and the tumor declared itself, and the parameters are abnormal, and the targeted biopsy here showed Gleason 3+4 cancer. So MRI improves active surveillance, and this has been shown in multiple papers, but in this paper, for example, you looked at just the MRI alone compared to some criteria that are used commonly. Epstein, D'Amico, and Capra. And it shows that the MRI alone cohort was closest to what they found on pathology. All these other ones had more errors in what they showed. But the MRI alone still had some problems, but not as many problems as some of these other ones. We've shown that, again, it's good for active surveillance. It's good for surgery. If you're planning to have surgery, you should have an MRI, because MRI, even 10 years ago, changed the surgical plan in 27% of patients and made it better. So basically, if the cancer was on one side, you could resect, you could do a prostatectomy and go deeper on this side, maybe even spare the nerves on this side. It's possible. But on the other side, you've left it alone and improved the function in terms of sexual function and urinary function. Take the nerves maybe on the areas that need to be treated more aggressively, but leave the other side alone. So these are different ways to do surgery, and it improves the actual surgical resection or prostatectomy. So we can also see the nerves with MRIs, and these aren't used commonly clinically, but we published a long time ago that using these MRI techniques, we can see the nerves really nicely when we need to. But we're still trying to find a way to put this into clinical practice. So MRIs improved the outcomes after prostatectomy. So in this paper, for example, if you saw a tumor beforehand, before radical prostatectomy, there's a higher chance that afterwards, if you don't do a proper radical prostatectomy, that you have a higher risk of biochemical recurrence. So the PSA starts rising after radical prostatectomy. So when you have a big tumor on MRI prior to radical prostatectomy, you have a higher chance that it might come back. So that's important to know and counsel patients. When we do a radical prostatectomy, we slice up every single one of those in this whole mount section. This is 3D printed from the patient's MRI, and they're sliced. And so we examine every single one of these slices. We have over 1,000 of these that we explore because we want to be that good at MRI. And we can say that when we see something dark and bright, so dark on T2, bright on diffusion-weighted imaging, bright on diffusion-weighted imaging, dark on the ADC, and bright on the dynamic contrast imaging after dye, that we can see a big tumor here. And we want to correlate the size of this tumor, the shape of this tumor, and other metrics with the T2-weighted MRI. We want to be very careful about how we're doing this because it affects everybody's life. It affects their sexual function, their relationships, and their urinary function. So it's very important that we get this right. MRI improves radiation planning in PET scans. PET scans as well improve radiation planning. So MRI can detect the cancers. PET scans can detect the cancers. MRI can show us the extent of cancers, and the PET scans can show us not just the cancers, but where the lymph nodes are. So that's very important before understanding what to do with prostate cancer. So again, this is high-risk disease. These are the sharks. This is a big tumor that's invaded outside of the prostate gland into the seminal vesicle and into the pelvic sidewall. So this is very important to understand how this cancer looks, where it is, and how to treat it. So this is where to sample it, where to treat it, where to know where it is. So MRI and PET scans help us really understand this. So we've shown that MRI improves radiation therapy because when you see a cancer, we can boost the areas of MRI visible cancer with radiation. So we can show that it does a better job when we call different kinds of cancers. All right. We can use all this data for artificial intelligence. And, that's a concept, artificial intelligence, that's in vogue. Everybody's talking about it, and we've been doing it. There's different ways to do it. There's deep learning, machine learning, and other ways of doing artificial intelligence. But the bottom line is, with all this data that we have, we've shown that it helps doctors improve. So basically, when we use artificial intelligence techniques, it helps us detect the tumors better. And this is the actual machine doing it. and it's as good as somebody who's an expert, and in some cases. So that's good. So that means that it'll help the community get better at interpreting MRIs. One of the problems with all this advanced imaging, MRIs and PET scans and everything, is that not everybody's as good. Some people are good at certain centers, but we want to diffuse that into the community. And one way to do that is artificial intelligence, to help everybody get better and have everybody treated better. So you don't have to go, to the UCLAs or the Michigans or anywhere else. You can do it even in your local hospital. And that's the idea, if we can do that. So MRI has improved the diagnosis of prostate cancer, helps us target the prostate cancer, helps us do a better job in understanding how to do surgery, how to do radiation, helps us predict who's going to recur after surgery and radiation. But we use artificial intelligence to make us better diagnosticians. But MRI also helps us see the underlying biology. So both on the genomic side and the protein side. So not only does it correlate with the Gleason score, but it correlates with the underlying biology that the genes and the proteins tell us about. So here we looked at some commercially available genomic tests. This is Oncotype DX, and MRI helps us improve the performance of Oncotype DX beyond what it's capable of. So the higher the PI-RADS score, the higher the Oncotype DX score. This is also for the Decipher test. You may have heard of the Decipher test, another set of genes that's looked at for prostate cancer. And in this paper, the mean Decipher score of MRI positive cancers was significantly higher than MRI negative cancers. So here is an MRI negative cancer. These two little MRI negative cancers, these are the Minnows. The Decipher score is 0.67. And MRI improves the performance of the Decipher test. The Decipher test is a very commonly used FDA-approved test. And in this paper, the mean Decipher score of MRI positive lesions or visible lesions was significantly higher than MRI negative lesions. So here's a Minnow, PI-RADS 2, Gleason group 1, and a lower Decipher score. Here's a shark, PI-RADS 5, Gleason group 3, and Decipher score of 0.79. So Oncotype, Decipher, when they're done on MRI visible lesions, the genomics are worse. This is also true for the 4K test. The MRI and the 4K, the MRI visible lesions are always worse on the 4K test as well. It's also true for the PCA3 test. Here, the cancers, the higher MRI lesions or MRI visible lesions show us the sharks, and the MRI visible lesions had greater Gleason 7 or greater cancers, and less no cancers, and less Gleason 6 cancers. So they show us that the sharks are visualized and that the underlying biology is worse. This is a paper from the Cedars-Sinai group that showed that the subset of genes, when they actually analyzed the genes that were associated with MRI visibility, had a poor prognosis. They were cell division genes, DNA damage, repair genes, and other genes. And those genes were worse in the MRI visible lesions. And we showed in a paper here in European Urology that a number of different genomic markers of poor biology, worse cancers, shark-like biology, were worse in the MRI visible lesions, hypoxia genes, and other genes. So one of my colleagues has called this nimbosis. That is a gathering of storm clouds. The ones that are the Minnows are monoclonal, have less hypoxia, are stable, are MRI invisible, have no bad histology on their biopsies. That's the Minnows. The sharks are MRI visible, have unstable genes, are hypoxic, polyclonal, and so on. And these are bad. The Minnows don't relapse, have very little metastasis risk. The sharks have much higher rates of relapse and much higher rates of metastasis. And this is what we want to see. This is what we want to see with MRI and PET scans or whatever else comes to pick out the sharks from the Minnows, right? 50% of the time, we're misdiagnosing men the old way. Hopefully, this will make it much better in the future. This paper basically showed that there's so many different things that MRI helps predict. It makes commercial assays better, like we talked about. The DNA-related features are worse with MRI visible lesions. Other biological hallmarks of cancer, biological pathways, and cellular structures are all worse with MRI visibility. In those tumors that are MRI visible, the whole biology is worse. And we also showed for the first time, this is true for protein expression. In this paper, we showed it's not just the genes, but that the proteins that come from those genes are worse. And when we see that, when you have the worst proteins, you have worse outcome. Those patients do worse than the patients with the better protein profile. And again, MRI visible cancers are better. MRI visible cancers are worse. They have worse biochemical recurrence. They have more metastatic disease. They have more patients that are MRI visible have progressed to death and other things. So MRI visible lesions tell us that the biology is worse, and it helps us really understand where that is. So when you see this, when you understand this, when you're talking about prostate cancer, you really want to understand the whole gland, and you want to understand where the sharks are, because when you find the sharks, they are probably going to be worse. Not always, but probably going to be worse. This has been shown for radiation therapy. So this has been shown for radiation therapy where a high PI-RADS score also means that they can recur after radiation too. It's not just surgery, it's after radiation too, that MRI visible lesions, the patients do worse than lower PI-RADS scores or MRI invisible lesions. So this is the gathering of storm clouds. That's nimbosis. It means that things that are MRI visible have worse outcomes. They have worse genetic markers, worse outcomes. So this helps us really understand for any individual person how to put together your personal risk profile. You have a number of features, all the MRI features, the PET scan features, your pathology features on biopsy, all the genomic data, putting all this together, and other tests that may come, putting all this together, possibly with the use of artificial intelligence to really plan a therapeutic pathway for you that's unique to you and your situation. So this is kind of being done, but it needs to be done in a much bigger and better fashion. So in summary, I would say that MRI and PSMA PET CT and PET-MR have dramatically improved the diagnosis of prostate cancer. Dr. Walsh told us was you need to find something that's going to make a difference in terms of imaging the prostate cancer, imaging the prostate, and that's there now. We localized the sharks, so the most aggressive disease. We help biopsy those areas. We may reduce the overall number of biopsies, and that helps men suffer less. It may improve the genomic performance of tests that are already available. We may incorporate artificial intelligence in a good way, not a bad way, to help diagnose different things, to help bring good sets of diagnostic criteria all across the world, not just at specialized centers, not just at the Michigans or the UCLAs of the world, and help patients choose more wisely what they want to do. The majority of men could probably have active surveillance, but if you're going to do treatment, you understand upfront what you're getting and what the chances of coming back are. So this is really what we want to do. And this is how we're trying to work to make this a reality. So thank you for your attention. And this is our information at UCLA if you'd want to get in touch with us, either in radiology, urology, or radiation oncology. And I'll be happy to take any questions. Thank you. And this is our group of many, many people who make this possible in the IDX program under our chair, Dr. Ensman, in radiology with my colleagues, urology, and then pathology.
Dr. Raman, that is excellent, honestly. And you know why it's excellent? It's excellent for a couple reasons. First of all, because I think it's excellent. And second of all, I've watched a lot of videos online in preparing for this juggernaut of an interview. And I've noticed that your slides and all your other talks are not as high quality as the ones you use for PCRI. Am I right or wrong, sir?
Oh, you're absolutely right. I redid most of them.
I mean, you got a beautiful shade, you got a beautiful color there. The images look amazing. I would love to see this talk myself a second time, which I'm going to do. You just kind of took your game to another level.
I wanted that shade to be somewhere between a Michigan blue and the UC blue.
Oh, that's a beautiful answer. And you know what I appreciate? Because we were talking off camera. At least Michigan, at least Michigan won the national title and we have the greatest football team in the history of college football, right? At least you know that.
At least we know that, yes.
Yeah. Do you know what I got from PCRI right after we won the national title after 15 years of service?
What did they give
Zip.
you?
I got nothing. You know why? For two reasons. One is because they probably didn't know about it. And two is because I can guarantee you, Mark Scholes, who has no football knowledge, had any idea that we won the championship. So
We were out here surfing, Mark.
thank you. I don't know. After all this talk of sharks and minnows, I'd be scared to surf out there. All right. You ready? I got a couple questions before we dive into MRI and PET CT. I want to talk about both. We got about 30 minutes, so I want to just take our time here. Now, I saw the funniest thing online after one of your talks, and usually I don't look at some of those funny comments, but it's a really good question because when I go to your bio, it says Professor of Radiology, Urology, and Surgery. And someone goes, how can he be a professor at three different professors at once? And I'm thinking, well, because the guy's a stud. The guy is world famous. That's why. But then I'm thinking, maybe I'll let him explain it. How are you able to get professorships in three departments?
I actually don't know myself, but somebody asked me if you want to be a professor, and I said, sure.
Really?
That was as simple as that. Because,
That's
I
good.
work with these people so closely. So sometimes they consider you family because, it's just you bail them out as a radiologist. You kind of bail them out, as you know, right?
There you go. See, that's impressive. But also what was impressive is I looked at what you do in your free time. And when I see that on a bio, sometimes it's BS and sometimes it's real. So one of the things you said is you like, because I'm a huge runner. I ran this morning before we decided to talk, so I'd be in my game. So it said you like to go running. Is that true?
It's true. It's true. Running, since the beginning, it's we run together as a family because I got my
Wow.
three boys into running, so we all kind of run. And but again, no marathons. But I have attention deficit disorder of some kind, so I can only run about 10K.
That's great. How long you been doing that?
Since high school.
That's
Yeah.
excellent. And then it says you like to travel, but it didn't say where.
Um, Anywhere,
You could pick,
anywhere.
you could, PCRI would send you on an all-inclusive trip. One spot, where do you pick?
Iceland.
Wow.
It's amazing.
Really?
Really amazing.
One place I have not been. I missed
Yeah,
a
one
meeting.
place you should go.
It's
Iceland is just blows your mind in terms of how anybody actually settled this place. And as you know, Greenland is not green and Iceland doesn't have ice. So but it's just the landscape there feels like you're on Mars or somewhere else.
That's incredible. I have to give a shout out to the active surveillance and other prostate cancer patients in Iceland. They've actually become a fairly tight group. They've worked with PCRI. So, Iceland. Okay. One
Yeah.
more thing the audience does not know about Dr. Raymond, and that is, and again, tell me if this is true or not. It says you speak Spanish.
I grew up in California, so again, I learned that in grade school, and I've spoken Spanish to, most of 30-40% of my patients speak Spanish. I have to speak. I have to, necesito hablar español.
That's awesome. You share that with Dr. Scholes. He speaks Spanish. What helps me when I'm in LA is I grew up with Farsi. That was my father's side. So that helps in Los Angeles. And then my mom's from Vienna. So I don't know many people that speak German in Los Angeles, but whatever. That's
There's
great.
on the way home, there's a German American club that we always drive by.
Really.
Yeah, it's a big, there's a big German connection here. Sure.
Well, so I think so. So what it tells me, because you know about football, you go running, you like Iceland. It tells me you're not all geek, you're not all nerd. You have a life outside of your job, and that makes me happy.
Thank you. Mostly, though, I'm the former.
That's great. I want to talk about something else before we talk about MRI and prostate cancer, because I went back through all of your publications. Yes, I have no life.
How
What
did you
I
do
thought,
that? I'm sorry. I'm sorry you had to do that.
no, it's impressive. It's and I almost should apologize that we haven't had you on earlier. But you know, we got you now at the height of our audience. So you've worked in a lot of different cancers and situations. I saw some things on kidney cancer and liver cancer. Do you want to comment before we get started on prostate? Are we outside of prostate in terms of imaging, whether it's kidney, whether it's liver, whether some of the other stuff that you've been doing or have done? Is there an exciting world out there? Because we only know prostate. Is there things happening imaging wise that's just as dramatic as prostate?
Yeah, you know what? One of the good things about doing something outside of an area is kind of bringing the cross pollination. If you're
Yeah.
just in an area, you just don't really know it. I have that same problem. Like, what are they doing in brain cancer? But they're doing a lot of exciting things there that we bring into prostate. So my biggest problem is, what's the best tool out there that we can adopt into prostate? And some of this work that I've done in liver and kidney cancer has been adopted to prostate. Why aren't we thinking about prostate cancer more like a liver cancer or a kidney cancer from the imaging point of view? Because all those cancers
Mhm.
are based on imaging. Liver cancer is entirely based on imaging. There is no biopsy. It's been eliminated.
Completely eliminated. Really?
Completely eliminated. They said no biopsy, only based on what's called the LIRAD score, which is the PI-RADS score is modeled after the LIRAD score.
Wow. Because
Yeah,
you remember the day, not that long ago, the idea of getting a liver biopsy was you'd be horrified.
right.
You're
And
gonna
hopefully
do.
there'll be a day when the prostate biopsy will be that too. Maybe not.
Wow. I really didn't think about that in terms of liver biopsy and how it's really not necessary anymore.
Not necessary. It's been not necessary for 10 years because of MRI. Again, MRI has revolutionized liver cancer care for the people, who can get MRIs. That's the problem with MRIs, access.
Yeah. Yeah. And in kidney cancer, are you excited what's happening there?
Kidney cancer, again, it's another disease where we didn't have biopsy, it just everything went to surgery. Now we've developed what's known as so again, we developed a UCLA score for the liver, we developed a UCLA score for the kidney and for the prostate. And the UCLA score tells us what something is a cancer or not a cancer, and then also tells us what else it could be if it's not a cancer, or what kind of cancer it could be. So every time we see something in the kidney, we give it a score. We're not always right. Nothing's 100%, but 80 to 90% of the time we're right. And
Yeah.
and we learn from our mistakes. We try.
That's just really interesting. Do you actually think that we will get to the day in my lifetime there where you're diagnosing prostate cancer without a biopsy?
I hope so. I
Do you
sure
think
hope
so?
so. Well, what I've shown is we can predict so many things that, well, maybe you can eliminate biopsy. I can't make a prediction like that. I mean, that's been
Yeah.
such an ingrained part of prostate cancer care, but we can get close because, you know, the at least we will hopefully eliminate the systematic biopsy and all the problems with that. We can at least target it to the region and do it properly, and maybe that'll be less problems overall in prostate biopsy. I mean, when you think about biopsies, doing a liver biopsy or a kidney biopsy is relatively simple. Most of the problems I hear are from prostate biopsies. People hate it. Like, just as a man, getting a prostate biopsy pretty much is like, what is more? There are probably few things you want to do less than that.
It's like a shark bite.
It's like a shark bite,
By
right?
the way,
It's down there with a shark bite.
there was so much talk about sharks, and you are in the Hollywood area. I want to test your movie knowledge before we keep moving on. One of the most famous quotes of all time was, "You're gonna need a bigger boat." Do you know what movie that's from? You're much younger. This is really frustrating. This is like it's like
You're going to need
Alex
a
and
bigger
Peter. They're
boat.
just too
I
young.
can't. My memory's going, Mark. So you have to tell me. I kind of
Gonna
vaguely
need a
know that.
bigger boat was in the movie Jaws.
I should
And
have
that
said that.
was in the movie Jaws.
I should
And
have
that
said that.
yeah,
What other shark movies? I should have said that.
it was Jaws. It was Roy
There
Scheider.
was Roy Schneider saying that. Yes.
Right.
Okay.
And he was
Yes.
playing Chief Brody and he was throwing out the chum and out came the big shark and he gets back and goes, "You're gonna need a bigger boat."
Right. Right.
Most
Right. Right.
famous lines. Anyway,
Of course.
see,
Very
we cover a
famous.
lot more than just prostate cancer here. Before we go in just to MRI, and before we spend the rest of our time on just imaging, which can spin my head, there's so much talk of imaging, it's incredible. People don't real now, maybe people do realize you're also a big fan of MRI guided treatments, I believe, and where we're going in terms of interventional radiology. And the reason I think it's a really cool field is it was either in one of your talks or one of your papers. I never really thought about it in terms of fibroids, for example, being treated today by interventional radiology. It's pretty dramatic, right? And then here's one that people don't realize: essential tremor is now being looked at, right? When someone has an essential, so these very diverse areas are now getting all this play in interventional radiology, and it's really messing with my head because, in a good way, someone the other day, a friend of mine said, "Well, I'm going to go get a steroid injection for carpal tunnel," and I said, "Have you ever considered an interventional radiologist delivering it in the carpal tunnel because landmark wise, it's difficult to deliver that compound?" And he said that this person said, "I never even knew that was an option. My doctor didn't bring it up." Fast forward a couple of weeks later, an interventional radiologist does the steroid injection and the person is extremely happy. My world is being surrounded by interventional radiology. Do you have any comments on that? Because you are immersed in that right now.
I think interventional radiology doesn't have to be done by just interventional radiologists. There aren't enough of them around. Every field can have interventional radiology. Urologists do it all the time. The key skill set is understanding the imaging well
Mm-hmm.
and what I call tip management. Can you get that tip exactly where you need to be? If you can't get that tip, you don't have no business doing it. But if you can get the tip to where you want to be, your target, that's
Yeah.
good interventional radiology, and you can do a lot of things well.
Are you excited about a certain type of MRI interventional treatment in prostate cancer?
There are many techniques that I think supplement what we can do. So, I like, for example, right now, I like the Tulsa treatment. I like
Also,
the
yeah.
inside tech treatment. I like those treatments because their safety margin is high because you are not only imaging with MRI, but then you're using the imaging during the treatment, and you're also checking the heating precisely, not only where it's heating, but also the temperatures. You can measure that all non-invasively with MRI. So I like that as a safety mechanism. So, but again, it's who you choose, and all those things don't matter. They're the same issue.
Yeah.
Does anybody need this? That's the biggest problem.
Here's a couple of thoughts. People are always asking, you just showed a picture of an open MRI versus a closed. And people ask all the time, and I'm sure they ask you, why can't they do an open MRI in prostate cancer? Why are these closed? Why open MRI machines advertise all over the United States? And I think if people were given the choice, I'd want to be in an open MRI versus a closed one because claustrophobia is not a small thing here. So can you do an MRI of the prostate, or can you do any of the things you talk about with an open MRI, or is that just not happening?
A closed MRI system is like the Cadillac of MRIs. In a physics world, the way MRIs work is the power of the magnet. So the power of the magnet in a closed MRI is well above that of anything that's open. And the reason that's important is because the power of the magnet determines how much the hydrogen ion will resonate with the magnet. And the resonance power determines a lot of downstream features of can you detect normal tissues? Can you get good T2 weighted imaging, diffusion weighted imaging, perfusion weighted imaging, and all that stuff, and how fast you can get it? So you can't argue with the physics, but the open MRIs are much lower power, generally much lower power. So they perturb the hydrogen ion much less. So all of those things that the hydrogen ion does when it's perturbed less are just less apparent at lower strength. But it's way better than getting nothing.
Uh,
Yeah. So you're not going to be like at the top of your game, but you might be in a two leagues below. In a sports analogy, you're not going to be playing for the Yankees. You're going to be playing for maybe Youngstown.
I see. I thought you were going to say you're playing for the Wolverines,
I didn't want to go there quite yet.
okay, you don't want to go
That's
there.
next year. That's next year.
Next year when we lose a lot of games, I gotta enjoy this for a year. Okay, so I walk into an MRI center. I don't care if it's for screening, what other reason. People always talk about this 3T stuff. Is this does this help patient advocacy? Do you got to make sure that when you go into a center of excellence and you're talking prostate imaging, that you want is this something you make sure that the person has is a 3T MRI? Is there a 4T? Is there a 2T? Like what?
Yeah, there is a 7T, but we're not using it for prostate clinically.
There's a 7T?
There's a 7T, there's a 12T, but uh right now those magnets that are super powerful are being used for the brain and to do very, kind of functional imaging and other things in the brain. So they exist. But I think if you can get it, a 1.5 or a 3T system is what you'd want to get. If you're super claustrophobic and you can't use an anxiolytic or a medication like that,
Yeah.
Valium or something like that, Ativan, and you can't get through it, then get an open, make a 0.5T open system. If you can get through that, it's better than getting nothing.
Wow. 7T and 12T, are those gonna, do you see that
I
higher
don't
T
right
coming?
now, not really for the prostate.
No.
Not really for the prostate. But I will say MRI PET scans are a thing. They've been a thing. And those will combine the advantages of MRI with the advantages of PET. And
Yeah.
for prostate cancer, they can be very powerful.
And I can't wait to talk about that. I still want to hang out with MRI for a little bit because I like learning about all this MRI stuff. If you go on some sites, I'm not asking you to be specific here. There's always this talk of metal. I got metal. I got a pacemaker. I got clips in my brain for a surgical procedure. I've got an implant in my ear. How are you dealing with when I think of the world today, so many people, I don't care if it's tattoos, and believe it or not, this came up recently, yoga pants. I didn't realize that some yoga pants have some metal strips in there. How are you dealing with the whole world basically walking around with metal? I heard that you can't get an MRI if you have metal. So what's your general thought on wearing metal or having metal in the body and getting an MRI? Can I still get one?
Well, if you have metal, then you should, if it's implanted by a doctor, they should have a card about what that metal was. So if
Okay.
it's a cochlear implant or some other implant in your heart, an
Yeah.
implant somewhere else in your spine, you always need to have either a picture on the phone somewhere what that was, because you can look up any implantable device under MRIsafety.com. So
Okay.
if you know you have metal, you can go on MRI Safety, and if you put the serial number in there, it'll tell you if it's MRI compatible.
Okay.
So if you don't have that information, then we have to kind of figure out what you have. So that's implanted devices by doctors. Now there are other things that people could have, shrapnel from war injuries or accidents or whatever.
Yeah.
And that just needs to be known where that is. If it's in the extremities, probably not a problem. If it's in your eye or your orbit, that could be a problem sometimes, and it could heat up or move. And so we don't want that. So then what we do is we urge you to get the MRI in a lower field strength magnet.
I
So
see.
so so the whole metal thing is mostly overrated, but there can be some certain situations where it can be problematic. 90% of the time, it's not a problem. 90+% of the time, it's not a problem. You just have to know what it is and where it is. With the very specific exceptions of it, something in the eye or some other very sensitive area. So
Mm.
the real problem is, will it heat up and cause a problem, or will it move and cause a problem? And that almost
Ah,
never happens.
So I'm glad you gave us that website also, because as I touch on 60, I'm just about to cross over there. I know Dr. Scholes is touching on 70. I always like to remind people that he's 10 years older than me. It makes me happy. And I'm
He
starting
looks
to,
good though. He looks good.
he looks good. There's no question. But me, I could be a male model.
I mean,
You know,
you also look good.
thank you. But
Yeah.
my male model potential. And
Yeah.
so I can tell you in my mind, I'm good looking. Outside of my mind, I'm not so sure. Okay, so I have friends now that have metal hips, metal knees. We're still okay there?
Yes. And the biggest problem there is not so much the metal, but the artifact from the metal, especially in
Artifact.
the hips, that can cause problems
Good
imaging the
point.
prostate. We want to do it at a lower field strength and use sequences don't cause so much artifact.
I wish that came out on the websites more. To me, on the websites, a lot of them that I looked at before we did this interview, is a lot of them sort of all or nothing. I didn't feel like there was a gray. I don't know. Maybe that's just me.
Yeah, and I think this is a bit confusing area, but I think if you go on MRIsafety.com,
Yeah.
gives you what you need to know. But generally, if you have implants, we can do almost anything. If you have a defibrillator, if you have AI, heart AICD and defibrillators, we
Yeah.
can and pacemakers, we can turn those off and scan you. But we have to know what they were. You have to carry a card or know what type it was.
Yeah.
Once we have that information, we can deal with all that.
That is awesome.
Yeah.
That is awesome. The other thing that confuses me about MRI is they use, I'm sorry, but you guys and gals throw around these words like fusion biopsy or in-bore biopsy. And a lot of people go, what? Does that mean that they're getting the biopsy inside the MRI? Does that mean that you're taking the pictures from the MRI and then just utilizing those with ultrasound to then do the biopsy with ultrasound? Does in-bore mean, so can you walk me through the in-bore fusion basics, and what does that mean if a doctor says to a patient, I want to do a biopsy for you in bore at UCLA, or I want to do a fusion? Can you walk me through those
So
basics?
basically, there's many ways to get to the target.
Yeah.
The idea is based on the MRI and or PET scan, you have a target. That's the shark that you're thinking that's the shark.
Yeah.
To get to that target, you got to get a needle into the target. And a lot of that comes down to the skill of the person doing it. That's the whole thing about interventional radiology. It's not just done by interventional radiologists. It can be done by anybody. The skill set is getting that needle into there every time reliably and safely. Safely and reliably, maybe the opposite.
Okay.
So you can use the MRI to do that. And the beauty of the MRI is it's WYSIWYG. What you see is what you get. You can't argue with the needle in the, like I showed you, that tumor. It's in the tumor. You know exactly where it is.
Yeah.
Every other technology is an approximation of that. So what we then do is not everybody can get an MRI biopsy. It's just not possible. So then the next step is fuse the MRI with the ultrasound. You fuse two things together. But there you have the error there is about 4 to 5 millimeters. It could be worse with people who are inexperienced. It could be better with people who are experienced. So then you have a tolerance of error about anywhere from 2 to 5 millimeters. Could be more.
Okay.
So if you know what you're doing, that works great. And that can be done in the doctor's office. Okay, so both the MRI and the in-bore MRI in the magnet and the fusion techniques can be done through the rectum, which is our most traditional way. It can be done through the perineum, like I showed, just right through the area between your scrotum and your anus, that area. After we do some numbing, we can do that there. So both of them are good, but I think that the gold standard for me is the in-bore MRI, because that one is the needle is imaged where it is. There's no, it is what you see.
I always give this preamble before. I never see the speaker's slides before. The speaker has no idea what I'm going to ask before, during, or after. They have no idea what's coming. But I want to do a quick ad for UCLA. I have found that when people call the PCRI, we've had a number of people where biopsy after biopsy, they know there's something there. They can't find the target. And eventually they moved to an in-bore biopsy at UCLA. I know this can be done in other places, and they found this significant tumor, right? So then that makes me think, man, it's too bad everyone can't get an in-bore biopsy. I mean,
Well, and I don't think everybody should. I think it depends on your doctor and the comfort of your doctor. I don't want to say that everybody needs one of these.
right.
But the problem is some people don't realize. I mean, I always want to realize my limitations and I want to be better, but not everybody thinks like that. So if there's a mismatch, there's got to be a reason for the mismatch. PSA is going up, but the
Yes.
biopsies are negative, right? If you just
Yes.
did the old fashioned way, the first time you get nothing, the second time it's even less. They're
Yeah.
going to get something. So why is that? Why can't we make that better? So with MRIs, it is better. But if you go out there and you have a PI-RADS 5 lesion, it's very high likelihood. It should be in the 90% range that you find something. And the biopsy comes back negative. Why is that? It's not because it could be because the MRI is wrong or something else is wrong, but more than likely, almost every case I've done, it's because the targeting was wrong.
Ah,
Something with operator, it's operator, the person who does it, that that variable is a big variable. It's in all fields, not just biopsies.
yeah.
Operator error is a big problem for anything. And to me, most of the time, that's operator error.
So in your experience, because this is not a small minority of individuals, they just can't find it. They know there's a PI-RADS 5, like you said, and then they go to the in-bore. Do you find when most of these patients go to in-bore, you go, they find it? I mean,
Every
because
time that's happened, I've found it. Every
every
time.
time,
Every time. And I've made my own mistakes on in-bore and I've gone back and found my own mistakes.
really?
Yes, because I can make mistakes there because maybe sometimes I'm overconfident. Maybe sometimes I was rushed. Maybe my pager was going off. I don't know what the problem was, but it's embarrassing, but I did it. But I did it to myself.
So what's the limitation on in-bore? Is it also cost, insurance? I mean, what's going on? Because I believe you. It makes
Well,
sense.
the problem is not a lot of radiologists want to do it. It is a little bit, it feels like a little, it depends on who is where doing it. And I mean, the whole point of prostate cancer care is it needs to be done in a team setting with all these people who are
Yes.
invested in it. So we have that at UCLA. You probably have that at Michigan. A lot of places don't have that. It's just individual people doing things.
Yeah.
And if you don't have a team who can bail each other out and help each other and help the patient ultimately, it's really hard to do.
I'm still kind of wrapping my hands around every time it went in-bore, you found it. I'm just
Every
going.
time. Every time. It's
Now, my first
maybe,
thought is, does every time mean twice or does every time mean lots and lots of
no,
times?
I'm talking about dozens of times over the last 10 years.
I love that story because when people come to advocacy groups, it's not always the straight cases, meaning, straightforward, like, oh, here's a biopsy, here's a PI-RADS, we got it. There's a lot of gray area. There's a lot of confusing cases, and people don't know what to do, and they
Yes.
don't know what to ask for. So I really appreciate the discussion of in-bore versus fusion guidance. That
And
helps
and
me
and
a
Mark,
lot.
I'll tell you that not everybody can get a transrectal biopsy. So we've tried to do other ways. We could go transgluteal, we can go transperineal, we can go anterior if we need to. So we'll find a way to get to that target
You've gone transgluteal, the butt
all the
cheek.
time.
That does not sound comfortable. That
It's
sounds
much
like
more
something you
it's
would do to someone you don't like. You put
it
a
does
needle.
sound like that, but we give the patients plenty of conscious sedation. They don't really even feel it most of the time.
So sometimes when you can't get there perineal wise, you can't get there rectally, you go transgluteal.
There are lots of situations where
Wow.
patients don't have a rectum or their rectum is damaged or diseased
Yeah,
from
that's true.
like ulcerative colitis, and we
Yeah.
go transgluteal. Yeah.
So a lot of these IBD type patients like
Yes.
Crohn's,
Yeah.
UC,
Anybody who has an
yeah, inflammatory
an
bowel
anal
disease.
fistula,
Sorry.
so many reasons
Yes.
they could not. Yeah.
Wow. Okay. I thought when I was watching one of your videos, you said transgluteal, and I thought, is that right? So I'm glad you brought that up. Man, this is a learning session beyond a learning session. Okay. Now let's talk about something else with MRI that comes up. Someone's been biopsied and then they want to do an MRI. So there's always this discussion of inflammation or bleeding and how long do you wait when there's been trauma to the prostate to get an MRI if you need one, or I don't know. There's always, when you listen to certain speakers, some people will say 4 to 6 weeks, 6 to 8 weeks, that when you image the prostate with an MRI, if there's a bunch of blood there and it's temporary, that's not a good time to image the prostate. Do you have any kind of general comments on that?
To
Because
me, I used to think the 4 to 6 week thing,
yeah,
the 4 to 6 weeks, I think those data are from the time when we routinely did a biopsy first and then MRI, which was done in the early days, like 15 years ago.
yeah,
You can see blood there for much longer time than that. So I don't really see a need to wait any. I don't see really see a need to wait. I would say if you can at all do the MRI before the biopsy, that's ideal because we can see blood there for months on MRI.
that is interesting.
So I wouldn't
So,
really wait. I would just do it. Maybe do the PET scan if the MRI is negative. Whatever you can do to get a diagnosis.
okay, you know the old saying, well, if you want to go to a surgeon, you better find someone who's done a lot of surgery. You want to get radiation, go find someone that's done a lot of radiation. But I don't think that's often a pathologist. You want to go to a good pathologist, someone that's done a lot of pathology. I don't feel like that is often applied to radiology. In other words, you've got to convince me in the audience that the experience of the person reading the image makes a massive difference. There's a learning curve with MRI. We're going to talk about PET later, but there's a learning curve there that's pretty steep, isn't there? Don't you want to go to a center that does a ton of these things?
You know, in every field that anything that does anything, the more you do and the smarter you are, the better you are. You want to go to the master machinist, you want to go to that person.
Right.
It's true in surgery. High volume centers do better than low volume centers for anything.
Right.
It's true in radiology. At our center, we have super specialized groups, meaning we have people who just do abdomen and pelvis reads. Only a fraction of those do prostate reads. So we have 40 people looking at general abdomen pelvis scans. Only 6 or 7 only read the prostate.
Huh.
Nobody else reads them because we want all the QC metrics to be sure that we are interpreting everything at a high standard, that our inter-reader variability, meaning radiologist A, B, and C are close to each other. And so as a result, only a few people read it, and we try to make sure that when they get something wrong, they know they get something wrong. We get the feedback. When the biopsy comes back negative for whatever they've called, they understand that. And that's what that report does. So it is critical in every step of the game, no matter what field you are, to go to somebody who's done a lot of it and somebody who's smart about it and somebody who recognizes they make errors. To me, all the stuff that I've done is because I feel like I'm not good enough.
Well, the reason this drives me a little bit wacky is because you look in the newspaper. Are there newspapers anymore? You look on the internet and it says, hey, imaging center here, imaging center there. They pop up all over the place. And I'm going, well, wait a second. I'm pretty comfortable getting an image there. I'm not so sure. Like, who's reading this thing?
That's very important. And it's also important for pathology. You got to know who interprets the stuff, how good they are. Because again, when you look at just general inter-reader agreement, that's the measure of quality. Radiologist, pathologist, urologist, A, B, and C.
Yeah.
How good are they with each other? And you want a group that works well with each other and does it at a high level and measures, and most importantly, measures themselves, measures their own successes and failures. And we do that.
Okay. Then I think we agree with each other. You should be just as critical of the person reading your scan and make sure they're experienced as you are of the radiation oncologist treating you or the surgeon, right? But then if
Yes.
that's the case, then why do we never see these signs on websites? Hey, you want a second opinion on your MRI, or let's just say even PET CT? Call blank, blank, blank. Call Dr. So-and-so at UCLA or USC or wherever. In other words, two-part question. Do you do second reads on MRIs? I mean, does your group do a second read if someone wants to get another opinion, if they're a little bit nervous about, or there's something ambiguous? Or do you only do that when people push it really hard? I mean, is this advertised?
It should be.
It should
be. Because
Exactly.
it's necessary. And believe me, half our business So today when I go back, I'll have 25 scans to read. 12 or maybe 25 or 30 scans. 12 or 20 or 12 of those 25 are done somewhere else, waiting for my second opinion. And almost always will disagree. 80% of the time will disagree with that opinion because it's being done by somebody who's just not, who's just not as good and or not as experienced. And for a PI-RADS 1 or a PI-RADS 5, they may be good, but it's always in the middle. All that
Yeah.
stuff in the middle.
Yeah. Like the threes.
Like the threes. And that's in life, you're sitting at where the threes are. The ones and the fives, you can figure out who had a home run. That's fine.
Right.
Yeah, you can figure that out. You can figure out who struck out. But what about the grounders?
That goes back to the discussion of inboard. It's like everybody knows the basics, but what do you do when the basics aren't applied? So thank you for agreeing with me because I'm so stressed out about this question and this sign that I need to take a sip of my Michigan Wolverines cup, my green tea.
Oh, there's the big M. I'm going to look away.
Yeah, you should look away. No, but I'll tell you, it really gnaws at me that I don't know, maybe PCRI should be doing it. Somebody needs. I brought this up last year at the conference. Somebody needs to advertise. Look, there are plenty of pathologists right now advertising second opinions. It's right on the website for prostate second opinions. If I would have told you that we're going to have advertising like that 10 years ago, you would have thought I was drunk. Now it's standard of care. You say, hey, we do second readings. Now there's second opinions everywhere in oncology. We don't see second opinions on MRI and PET CT. I'm throwing this sign away for now. I'm just happy that you validated it. Thank you.
I think, Mark, that's very important. But again, it's the group that does it that should be invested in prostate imaging,
right?
Invested in everything prostate. They should be doing just like the good pathologists are prostate pathology people. And even in urology, the good practitioners practice mostly prostate. I mean, they live prostate world, like you said. Our world is prostate cancer. They live that world, but it's also true for radiology and for pathology. But the only thing I would say is there are probably not enough radiologists, and that's where artificial intelligence comes in to help us reread and give them. It's not perfect, but it's getting better, and it helps average people get better. Yeah. Better people make less mistakes.
I just see a lot of pop-ups wherever I travel, and I'm just thinking, hey, it's not that I'm saying a pop-up's bad. I'm just wondering, hey, where would you go if something's ambiguous? Well, so basically you do these things. That makes me happy that you do them. All right. Nobody argues anymore about how important an MRI is in telling you your PI-RADS score, your chances of having a significant tumor. But when I watch people get up nationally all the time, they'll say, well, it's still, the MRI still misses about 10%. Some people say 20% of significant tumors. And I'm thinking, and you touched on this, I'm thinking, well, that's not exact. I mean, it's a great score overall. It's a great batting average. But why is it missing those 20%? Did you answer that? I mean, I think you did, but can you re-explain? How are we going to get to those 20%? And the second part of the question is, I think you said it. You said even the ones that we miss that are invisible, they have sort of a different feel to them anyway. Can you talk about that again? Why are we missing, and why should I feel good about you missing 10 to 20%?
That metric has advanced so much more than what we used to have, right?
Right.
Before it was like half or whatever. Now it's up to 80 to 90%. We do miss 10%. Some of them are because the tumors are just not in clumps. When we look at this on pathology, and we do every case that comes out, the ones that we miss tend to be the ones that aren't in a nice clump. They're kind of diffuse. So those are problems. They're not like these nice round balls. They're kind of like this. They're kind of like a little spider. They're just kind of like little spider legs. And we don't see those as well on MRI. I think we do a little bit better when we combine MRI and PET scans. We find more of those things. There's certain types of tumors, like mucinous tumors, that just don't, they look like a background on MRI. So we do miss those. So I think, I mean, if all else fails and the PSA is rising and you can't find anything on anything, you probably should get a biopsy. Probably should get a carefully done systematic biopsy. It's just, so it's not totally dead to me, but I wouldn't want one if the MRI shows something, because when the MRI shows something, then you could target around it. But when it doesn't show anything and you have this high risk maybe a high family risk and all these things, then you have to do it because it will miss a few 10 to maybe 15%.
So there you go. PSA is rising. People not sure what's going on. It's been missed. I know we're not there yet, and I'm sorry I'm jumping the gun a little bit, but why not then just ask for a PSMA PET?
Oh no, yeah, I think that's reasonable. Yes, I think like I said, the PSMA PET and the MRI together.
Yeah. Yes.
Okay, it's not a night and day difference, but it's better. So PSMA PET will pick up 80. That was one of my slides. In our hands, PSMA PET will pick up around 80%, 83% of the cancers, 85% of the cancers. MRI will pick up anywhere from 80 to 90% of the clinically significant cancers. The
Yes.
two together will pick up close to 90% because some will be missed on PSMA, some will be missed on MRI. We put them together, they're better, but they're still not 100%. The ones they
Wow.
miss, like I said, though, are the lower grade, smaller ones. Very occasionally, you'll find a high grade big tumor that's missed on both. And those are the mucinous ones, for example.
Yeah. Boy, that's interesting. That's really, really interesting.
So we're
Okay.
getting to 90%. I think we're close to 90. I'm not sure how much better we can get with this, what we have now.
It's so funny because you know this 3, 5 years ago, the idea of combining an MRI with a PET. Is that where we're going now?
I think so. I think so. I
You're
mean,
feeling that good about the data?
I think so. I think, you know, PSMA is too good not to just ignore or use as a secondary test.
Yeah.
I don't think you need it all the time, but I think if you're going to make critical decisions like the ones we talked about, it's necessary. MRI is negative, PSA is rising, PSMA for sure.
Yeah.
MRI is discordant, then I would do a PSMA. You want to go to surgery or radiation, I would do a PSMA.
Huh.
Right? You want to do active surveillance only, maybe MRI is okay.
Maybe MRI is okay.
Yeah, maybe MRI alone is okay for that.
What if you're one of those that you are in active surveillance and you're teetering, you got a little bit of pattern 4 going on. You're one of those, you're not a minnow, possibly you're not the shark, maybe you're cod, maybe you're salmon.
I don't know
I'm
the
just
answer to that. Maybe I don't know the answer to that yet. But
yeah,
you know,
yeah.
this is where we're getting. But I think right now the data I'm feeling confident about is if you're able to do it and you're able to do it in a good place, I would get the combination, especially for critical decision making.
I'm sorry to ask you this next question, but I ask it of everybody who does MRI because it's never going to go away. I looked online, it's everywhere. It's the MRI 2024 controversy. And then we're going to talk about a little bit about limitations. And then we will go to PET CT. Here's what Shakespeare said in my mind, or Hamlet, actually. To use contrast or not to use contrast. That is the question. I'm sorry to do this to you. You know what?
I'm gonna go like Hamlet. I'm gonna go a little sad.
All right.
I'm gonna go a
I'll
little
take
sad.
that. I'll
I
take
need to go
sad
back.
Steve or no, Steve.
Yeah, I I will say that
I am just on pins and needles, just waiting to hear your answer. This is actually important stuff. I can't wait to hear it.
I think you don't need to use it. I don't think you need to use it. I think if for most situations, there's no good reason to potentially use it. 90% of the information, 90 to 92% of the information is on the T2 and the diffusion weighted imaging.
Mm.
However, about 7 to 8% of the time, you may only find the cancer when you give the dye and it shows up in that early phase. We image a whole bunch of times after we give the dye. It's like taking a multi-shutter image of the same area after you give the dye. The tumors light up. Tumors light up generally. So about 6 to 8% of the time, that's true. And you may find a tumor only in that situation. There are other reasons to use the dye. If you've had radiation or surgery, sometimes the tumors only show up with the dye. So it does help. It doesn't help most of the time, but it does help on occasion. So,
Okay.
so the answer is, I agree with the fact that you don't need to use contrast most of the time. Most of the images, most of the time, the information's all there.
Well, what I put in here was metal. Is I found that the first paper I saw was from Cleveland Clinic in the Journal of Urology, and now other people are accepting a certain position on it. With some of these BPH procedures, like when they put metal clips in there, UroLift, there's a question of where do you stand with these procedures that place metal in and around the prostate? You have to use dye there, or can you?
Yes, I think so because they create a lot. They can create a lot of artifact.
Oh,
They can
no,
terrific.
this is
So
yeah,
I would say
great.
if you're going to do that, at least get a baseline MRI to see what was there.
Yeah. No, but this is important because people are running around and then, UroLift's a good procedure. But if one of the catches is,
Yeah,
you
it
have to
makes all
go
these imaging things hard,
because it makes the image harder to read,
harder to
right?
interpret because you have a lot of artifact and there's no way to get around that now. What are you going to do? It's already in there.
Oh, there are so many ditties in this talk. Alex, Peter, I know you're watching. I am foaming. I'm so not foaming in a bad way, foaming
Yeah,
in a good way. I want to talk a few more catches. So one of the catches of having some metal there, and you might have to get the dye, but gadolinium in and of itself, when I talk to most people, I understand the worries with certain individuals, but they also remind me of the millions and millions of scans that if it was truly really problematic for most people, that you would have seen a signal already. Is that fair to say?
very fair. So I think the problem is there's been scares that are outsized of what's actually happened. So
Okay.
gadolinium has been around since and FDA approved since 1989. So in around 2006 or 7, they found in a certain subset of patients were having these skin reactions, and that was called nephrogenic systemic fibrosis. It was
Ah,
about 200 plus patients.
NSF, yeah.
Yeah, NSF. And that problem occurred in people who had multiple medical problems. And in our situation, it occurred in patients who were post-transplant, multi-organ failure, really sick, and they were given the dye. And those patients were more at higher rates of getting the NSF. So, but that problem has been virtually eliminated by not giving those kinds of patients dye.
Okay.
It's
Okay.
not in an outpatient population like a prostate cancer population. It's not in that population. And plus, the dyes that were most associated with that particular entity, which is also small, are no longer being used. So both of those things has eliminated that problem. Then the
Okay.
next problem came that they've noticed that in the brain of patients who had multiple gadolinium-based exams, so if you're getting a cancer scan, that some parts of the brain, the center of the brain, had gadolinium deposition, meaning they found that on successive scans, you could still see some gadolinium there. And that's been true for other parts, other organs. But what's not been shown is that that's actually caused a problem in any given patient. Any kind of memory problem, cognition problem, your intelligence problem, thinking problems, or any other kind of problem. They've noticed that the fact that there's some deposition, but not a problem from the deposition. So to me, okay, it's there.
Yeah.
So if you need the scan, there's no reason not to do it. If you don't need the gadolinium scan, don't do it. But it doesn't tell me not to do it because it's fundamentally a very safe drug. A few problems I've ever seen with it include allergic reactions. That can happen.
Yeah.
And so that can be serious, but it's really pretty rare. So if you don't have that problem and you need to use the dye for some reason, there's really no reason to not to use it.
Okay. But in the end, if someone just says, your choice, doc, you would like to use it if you could to
I would
help
like
with
to
that
use it, but
6%.
I don't insist on it. If you have some phobia or anxiety about it, don't use it
Okay.
until you absolutely need it in the situations what I outlined after surgery or radiation.
Okay.
That's an absolute, it's really helps in those situations.
Really, so as you move along there, okay, the stage part. Okay. All right. That's really good to know after surgery and radiation. All right. Tell me about,
Maybe also focal therapy, Mark. Maybe also focal therapy.
you
Because
took the words right out of my mouth. Focal
yeah,
therapy. Okay. Great.
yeah.
So post radiation, post surgery, and after focal therapy, that's a lot of people that you're excited about getting the contrast.
Well, I'm not
Okay.
excited about it. It's just it helps a lot. Like,
I know. I mean, yeah, it helps
yeah,
you.
it helps a lot to see where the tumors are. And maybe with using PSMA more, maybe those will also it may be less important. But right now we don't know. So right now in 2020, March 2024, I can
Yeah.
say that I would use gadolinium absolutely in those situations, not worrying about your ability to think or any other problems with you.
No, people don't talk much about diet restrictions with some of these images. Are you, because I know you don't want the prostate moving. I remember doing an interview one time for someone in New York, and they said, well, they want their patients on a low residue diet before an MRI scan. They don't want much rectal gas. They don't want a lot of gas in there. Is that still the case? Where are we with all
Yes,
this?
I think whatever you can do to minimize motion is very important. So MRI is very sensitive to motion.
Okay.
And so are these techniques, the T2, the diffusion, the perfusion, they're all sensitive to motion. The less, and motion comes from breathing, motion comes from your just moving around,
Okay.
motion comes from the bowel, your intestines moving and the rectum moving. So if you can minimize all that, it's better. And gas is very important because gas distorts a lot of things. So we want them to empty their bowel, especially their rectum, beforehand because gas really gets in the way. So we try to do all those things to minimize any problems.
So they change their diet. You want them
We do a
to
Fleets enema.
eat
We give
cinema
them,
too.
yeah, we
Okay.
do all those things to just help them get rid of all that stuff in the rectum as much as we can. We don't
Okay.
always succeed, but we try. We try.
Okay. I hope you're not in a hurry because I'm having too much fun with this and we're answering too many questions. So can you hang in there just a little bit longer?
Absolutely.
By the way, you want to hear something? You can show you how much, again, this is proof positive I have no life. I read a headline before this interview. It said, oh my gosh, this was a major headline. It said, there's a helium shortage, and helium's used to cool down the magnets of the MRI because helium can get down to minus 450 Fahrenheit. And I thought, I never thought about that. So are we going to be able to do MRIs in the near future because there's a helium shortage? Is there a helium shortage? What's going on,
I think
Steve?
it's gotten better, but there still
Okay.
certainly is. And so for the high field magnets,
Yeah.
they're cooled with helium.
Okay.
For the low field magnets, the ones that are open MRIs and the lower field magnets, they don't need helium. So, maybe we'll go to that. We're actually installing a low field magnet at UCLA. Maybe you are too there. And if the images come out good, we wouldn't worry about helium.
But right now, using helium with the prostate MRIs. I
Yes,
mean,
for the 3 Teslas and the 1.5 Teslas, yes.
such an interesting thing. It's a business
It's
everywhere.
all related.
All related. We're all interdependent. We're all interdependent. I also read someplace where I always find it interesting in an MRI scan, most of them will say the prostate size, right?
Yes.
Most of them, most of them will say 68, 42, 93. It sounds like a quarterback making a call, I know. But but I just thought to myself, and I looked at it, and there was a couple formulas. There were one or two different formulas, and I thought, well, do you feel comfortable that MRI, and you can even comment on PET CT if you want, is that because you use it for PSA density? Size is important for measuring and using it for certain formulas. Do you find that the MRI is actually sensitive and accurate at measuring prostate size?
Yes. For the
Okay.
most part, yes. But if you truly wanted to know the prostate size,
Yes.
almost any software will calculate the volumetric prostate size. And so that's very sensitive. If you just do a calculation based on the length and the width and the height,
Yeah.
that's cruder, but it approximates. So it's not as good. So if you're going to get size, you actually want to measure the true volume, which you're capable of on all those modalities. You can do it on ultrasound, you can do it on CT, you can do it on MR. You got to do it the right way and the
So
right software.
if I see a UCLA or another MRI scan that says my prostate is X in size, I should feel comfortable that's
Very
accurate.
comfortable. But if we measure it, if we're saying we are calculating the volume based on the tridimensional measurement, length,
Yeah.
width, height, that's not
Yeah.
as good. That's
How
an
do I know if they've
approximation.
how does Joe whoever know that they've measured it the right way?
They have to ask the question how they've measured it. Yeah. They got to ask. I'm
I
sorry. They got
knew
to
this
ask.
was a hot topic.
I, I can't tell you because I don't know at center A or B what they do, but
Yeah.
most people who are good at it give you a volumetric measurement. In other
So
words, it's not a calculation. It's the actual thing that's you contour the whole prostate and that's the volume.
so are you saying to me if I see on a printout somewhere, I don't care what state it says length times width times height, it gives and it
Yep.
shows the three numbers. is that an indication that it was measured correctly, or is that just an indication it could not have been measured correctly? I
You
have
have no
no
idea unless they say it's a volumetric measurement. If it's a
man.
three-dimensional volumetric measurement, it was measured not, they're giving the three numbers, but they actually measured the true volume.
So they have to tell you whether or not it was a volumetric measurement.
Or a calculated measurement. If it's a calculated measurement, it's not as good.
Right. That's where you can see in some of these equations, actually, it's underestimated. I mean,
Underestimates, possibly overestimates. It's just, it's out there, gives you kind of a number to throw around.
I know, but Dr. Raman, can you
I would,
understand this is such a crucial measurement to PSA density. Like
you know what?
I
The
thought,
ACR is developing standards for all
yeah,
these things. And hopefully, like breast cancer, prostate cancer imaging will be regulated in that to that degree.
that is really fascinating. Oh, all right. The last question is all these people having prostates out, they're getting radiation to the prostate, and all people talk about is PET CT, which is the last thing we're going to talk about. But can you please comment? Everybody thinks the MRI is just basically intraprostatic. It's all about seeing the prostate. If you look at a report, an MRI report, it's commenting on adjacent lymph nodes. It's commenting on seminal vesicle involvement. It's commenting on extraprostatic extension. Can you please give a rah-rah cheerleader moment to the fact that the MRI does a lot more than just tell you what might be happening in the prostate? And what if you don't have a prostate? It tells you adjacent structures. Isn't that correct?
Very much so. I will say that the resolution of the MRI compared to a PET CT. So we got to distinguish between MRI, PET CT, and PET MRI.
Okay.
They're three different things.
Okay.
The resolution, that is, how fine can you see the edges, is best on the MRI. If you want to know where the tumor is relative to the edge of the prostate, to the nerves, to the sphincters, both above and below, to the bladder, to the rectum, that's all MRI. That's the workhorse of MRI. It'll tell you all that. And yeah, so if you want to know, if you want to know if a tiny node is active, MRI is not going to be that helpful. It's not as good. The combination of the two with either a PET CT fusion or PET MRI, the PET MRI right now is probably the single best technique we got. PET MRI, but not a lot of places have it. Not
exactly. That's the problem, right? And then
that's a problem. It's a very complicated technique. It's expensive, and there are places that are using it, but it's not in every corner. It's not every imaging center that's advertising that you're talking about.
Yeah, and then what insurance is going to cover a double image?
Well, yeah, exactly. That's the other problem. How do you pay for it? That's always a perennial problem with any of these things.
Well, some people are paying out of pocket. I almost lost answers. So people in California, I'm not against somebody calling the center and saying, how much is this going to cost me if it's not covered? I mean, because what I'm seeing when people do these cold calls, and you can comment or not on it, is that the price differential is pretty wide in some cases. I mean, so I don't know.
It is very wide. And it's worth, if you are, I am very sensitive to the fact that our mechanisms to pay for all these things are very fragmented. Some people, it works out great. Some people have big co-pays depending on where they get their imaging. Yeah. And I think it's worth it to shop around, because ultimately it's better to have it, even if it's lesser quality, than not have it.
Interesting.
Yeah, that's what I tell people. I mean, obviously I would want everybody to do it at a Michigan or a UCLA or wherever, but I understand that you can't, it's just, it's pricing hard. Structure is such that sometimes it's unaffordable.
It's hard. All right, you want to just talk PET CT now?
Sure.
Did I miss anything on MRI, or did I just completely exhaust that journey to the point where nobody wants to talk about an MRI all day long again? Or did I think
you're close to that point. You're close to that point.
Is there anything else that I missed that you want to emphasize about MRI that's a key take-home message, or did we cover it?
I mean, the key take-home message is it's not perfect. It's getting better. The problems it's unequal. So some places do it really well and some places do it really poorly. You got to find, like everything else you do in life, you got to find the best painter for your house.
Yeah.
You got to find the best guy that's going to do your kitchen floors, and you got to find the best person that's going to do your surgery or MRI, and you got to find that yourself. It takes some doing. It's not equal. It's not equal. It's not equal.
Oh, well, that's a good point. And then I want you to always remember, as you say that to other audiences, there's Mark Moyad holding the sign going, when are you going to advertise second opinions? When are you going to do it, Dr. Raymond? Come on. Anyway.
We should do it. We just need to clone ourselves into 15 times, and I don't know where we're going to find these people.
You're going to find it. I mean, UCLA's helped start. Well, let's go. We're going into PET CT. I mean, wow, right? Thanks to UCLA and UCSF, they got the first one FDA approved, the gallium. So let's talk a little bit about how about we just start with the different types of PET CTs. All right, let's just talk about them for a second, and then we'll go into some basics. I just don't know if you comment on them. Look, I don't care to use trademark names like of drugs or all that. I don't work with these companies. And if I did work with them, I'd still use the trade name because trying to use a generic name makes people confused. So you have choline that's used primarily at Mayo. You have fluciclovine, which is Axumin. You now have several different types of PSMA. The type that you all started at UCLA. You've got these two other types that have come out. All this is exciting. Then you got one that was sitting out there for a long time called FDG. There's another one there. So there's different ones. Do you just want to make a general commentary? I mean, everyone seems to be obviously great, and when it comes to prostate, is gravitating in this direction. But some of these still have roles. And so I didn't know if you wanted to comment on my new list, because the list is getting bigger every year.
I think if you are talking about PSMA PET CT in 2024, you're really talking about the bottom, the one on the bottom. And the reason for that is it's the most widely available, and overall performance for gadolinium or Pylarify or Posluma is right now the best that there is. There are certain situations where you could use Axumin. It's not quite as good as pretty good. Yeah. And there are certain situations where it may be positive and the PSMA is negative, but those are the distinct minority. So most people aren't going to be using choline because they don't get it. They can't get it. You can get it at Mayo, but you can't get it anywhere else. So, okay, if you're at Mayo, great. But you can get Axumin everywhere. Generally not as good as the 3 PSMA agents. In a few, again, like a few percentage, we're talking about less than 10% of the time, some prostate tumors show the Axumin, but they don't show the PSMA because they don't express PSMA that much. But that's less than 10% of the time. 90+% of the time, your PSMA scan, whether you get gallium or one of the other two agents, is going to do a great job for you if you do it at the right place. Yeah, it's going to do a great job. And again, we can't get into the weeds because we'd be there all day. But yeah, if we're talking about 90% of the time, it's that good. That should be good enough.
Yeah, you sort of get to the philosophy where it's the bigger point is just getting one done versus fighting over which one necessarily is better.
Exactly. Getting one done and getting one done at a good place.
Yeah, a place that reads these things. Again, not one of these mom and pop pop-ups.
I hope not. And I mean, some of them do a good job too. You just got to know who does a good job.
Right. Yeah.
Hopefully your urologist knows or your radiation oncologist knows. I don't know. Somebody should know who are the good people.
And then I'm going to throw in some terminology that comes after you get one of these scans. Can you kind of explain this a little bit? Because I'm going to jump around here because of the sake of time. I always see this thing say is SUV. And when I think SUV, I think of a car, right? I don't standard uptake value. And they see these numbers on their, patients get their reports now as they should. They should, like they have just like they have a file for their taxes, they should have a file for their reports.
Very important.
So you see this word that's bandied about all the time. SUV, it's SUV this. SUV is important. High SUV is more concerned. How do you put your hands around this in your position explaining SUV to patients?
I explain it kind of like in the old-fashioned light bulbs when they had wattage ratings. Yeah. That's what an SUV is. How bright it is a function of how much it expresses PSMA on its surface. So low SUV would be like a 20-watt light bulb, and high SUV maybe a 100-watt light bulb. So generally, the 100-watt light bulb or high SUV means it's, number one, it's probably real, and number two, it's probably going to be a higher grade type of prostate cancer. There is a range. But in general, when you go from Gleason 3 to Gleason 4 to Gleason 5, the curve goes like this. The line goes like this, meaning that the majority of the Gleason 5s, higher Gleason groups, the higher PI-RADS groups show more SUV.
So
it's brighter. It's brighter on the wattage index.
So the higher the SUV, the more likely it is it's a shark?
More likely to be a shark.
Really?
To get a bigger boat.
Yeah. See, you're going to use that in your next talk.
I am.
Right? You'll be driving home.
I should have put more Jaws in there, but I figured, well, it's 2024. Does anybody remember Jaws?
I know that's a good point, but there's a lot on the internet there. But you'll be driving. I was going to say after this talk, you're going to be driving home, but probably not. In LA, you'll probably be bumper to bumper home.
I'll be crawling home.
Crawling home. Good. So SUV is important. But keeping in mind that, well, I'll go into that in a second. But the other thing is, I want to talk the Achilles heel of PSMA PET scans, because I want to talk about this. What about these false positives? Are there false negatives? But what about these false positives? And before you answer the question, I want to talk to you. I went through a couple of your papers, and it was explained well, and also some of the videos. False positives occur, and here's where some of the reasons for false positive, right? You got some rib fractures or other fractures, maybe a spinal compression, I don't know, Paget's disease of the bone, right? And then here was one I saw on a talk, uptake in a ganglia, which is a sort of a nerve bodies, and there are lots of little nerve cells around. So I'm seeing all these, and then I saw this one called after you get radiation, you can get an increase in PSMA that might not mean that you have cancer. So, okay, I hate to overwhelm you with this, but I'm finding lots of reasons for false positives with the PSMA PET. How do you answer this?
Okay, so let's take the situation of early in the diagnosis.
Okay.
So early in the diagnosis, there generally aren't a lot of false positives. So in the prostate, certain kinds of BPH nodules can give you some PSMA uptakes. So let me take one step back. The PSMA protein is expressed on lots of things. It's expressed in blood vessels and other tumors and certain reactive processes. So there's always a background amount of PSMA kind of expression throughout the body. It's overexpressed in prostate cancer cells for the most part. So that's what we're using. Hey, this cancer overexpresses this protein, and these agents bind to that protein. So even if this protein exists throughout the body, I just saw a case last week. A kidney cancer was brightly expressing on a PSMA scan because that particular tumor happened to overexpress PSMA.
Wow.
And that's the answer to your question. So yes, if it makes sense, if you have a primary tumor and a node in the right area, that's probably real. If you have a primary tumor and some other random thing that shows up somewhere else, that's probably not real, and you have to try to explain it some other way. So again, it comes down to expertise. Just because it's bright, high SUV or intermediate SUV doesn't mean it's real. If it's really high SUV, it probably is real, but you gotta look at the underlying imaging. Is there a rib fracture? Where is this thing?
Yeah.
But in my mind as a radiologist, I'm always asking, what else could it be? Am I right when I give a diagnosis? If you don't ask that question, you're going to make mistakes.
Does the MRI help you figure those out?
Yes, in many situations, yes. So the MRI, two together are better together.
I know. I'm so excited about that, but I know a lot of people watching are going to go, how am I ever going to get two? I can't even get one right now, with insurance and all this.
I mean, one is good, but two are better. I can't say everybody needs both, but I'm just saying that the answer to your question, it's complicated, but you got to look at the underlying reason for why something is bright.
Yeah.
Most of the time it makes sense. When it doesn't make sense, you got to have an alternate explanation.
Well, and that brings me to PSMA. So the false positives happen. I should say that. And then, so basically what you're saying is after radiation, you can just see like a flare. You can just see.
Yes. You see that on bone scan. You see it on other things. You can see it sometimes on PSMA.
And that doesn't necessarily mean the cancer is there.
No, you just know not to image too early. You give it a kind of a window before you start imaging.
But then what do you do about all these people on androgen deprivation therapy? How does PSMA do on hormone therapy, or that has no role right now? I mean, how do you
I
think?
mean, again, I think when you're dealing with things like that, it's complicated because it's going to decrease the PSMA uptake for sure. It's going to
Yeah.
change the way MRI looks after when you have androgen deprivation, the MRI looks gray. And
Okay.
that's why the dye makes a difference. That's why if you're on androgen deprivation and the PSA is rising somehow,
Uh-huh.
the dye helps. PSMA may help, but we don't know. It takes a certain amount of PSA level to get
You
that.
mean the dye helps for the MRI?
The dye helps for the MRI to figure out where the tumor is in the prostate or in the surgery bed.
Really interesting.
PSMA, you don't do it too early. So if the PSA is really low, under zero point 0.5, it's not going to be that good. You're going to be false negatives.
Yeah.
If the PSA rises above 0.5, it's much better.
Well, that brings me to something when I'm about to show this chart that's advertised everywhere. So you're looking at things metabolically with a PET CT, right? So
Yep.
PSMA. So sometimes the dilemma is not just whether or not the PSA is high enough, it's also how it's trending or the kinetics, if it's moving fast. Now, when I think of metabolics, I want to believe that if a PSA is still low, but it's moving up quickly, that's a good time that a PSMA can catch the cancer on the scan. I mean, in other words, is it not just the number and how high it is in terms of a chance of a scan being positive after primary treatment, for example? What if it's low, you're doing an ultrasensitive PSA, but it seems to be moving up quickly? Do you catch more cancers with velocity moving, or does that have nothing to do with it anymore?
I don't think that same concept really applies to the PSMA scan. I think the total
Okay.
level matters.
The
The
total level.
velocity may matter. I don't know. I don't know it well enough to tell you that answer that question. But to my knowledge, a high velocity at a low PSA value is not going to help as much.
Okay. Now, I just want to announce to the world I'm about to introduce Dr. Raman to another controversy. Here it is. First, I'm going to give him kudos. This is what they advertise. So after you've had surgery or radiation, you want to catch the cancer early. You could still get a second shot at cure. We know all about this stuff.
Yeah.
And the lower the PSA, the higher. This is from the Condor trial. So if the
Yeah.
PSA is less than 0.5, because a lot of people advertise, they get all fixated with 0.2. Once my PSA hits 0.2, I want my PSMA. But only about a third of those scans lit up, right? So, but when
True.
I
And that's
start
what I
to,
was trying to say. Wait for it to get to 0.5. You got to wait.
so see, that's what's interesting because that's not what's advertised. What's being advertised and suggested out there in PET CT land is the moment you hit 0.2, let's move. So you're saying you're more excited about hitting that 0.5 threshold, right? Where it becomes 51% or higher. And in all due, tell me if I'm wrong here, though, Steve, honestly. These are old numbers from an older trial that was published in 2021. Some of the readers are getting so good, and I looked at the confidence intervals on these. These numbers are getting better and better at the lower PSAs. Am I right?
I think you're right. I just don't know that they're that much better at less than at 0.2. At
Okay.
0.2, I mean, you can get it, but a negative scan doesn't mean it's negative.
Right.
I would do it with the MRI with the dye. I would
Uh,
do it. I would do the two together if possible to catch that extra percentage of the ones that are the ones that light up with the dye versus this where they may not quite light up here. So the combination of the two will be more sensitive.
are you saying that the combination of the two are more sensitive if you want it done at a PSA of 0.2? Or are you still
Yes.
saying wait to point? So if you're one of
Yes.
those people that say, I'm not waiting to 0.5, I don't care what Dr. Raymond says, I'm going to get it at 0.3. You're saying, well, then at least get both?
I would say get this one. If it's negative, then get the second one.
That is interesting.
Yeah.
What about if it does hit 0.5 or go higher? You're feeling much more confident in the
Much
PSMA.
better. Yeah, much better. Again, if we did a PET MRI, we
Yeah.
wouldn't have this problem.
Yeah.
But these numbers are still relevant. And that's why I say 0.5 is where we start getting comfortable that the PSMA is going to do a good job.
You know why I yelled out to the world about the controversy, right? Because the longer you let the PSA rise, for example, after surgery or radiation, that's when the radiation oncologists go, hey, I want to hit this thing earlier. The earlier the PSA, the more chance for a cure. Why are you waiting, Steve, for this to go so high? What say you?
I can say that the scans are what they are. So I would say do it, but you can't rely on a negative result. It's only rely on a positive result. Yeah.
Yeah, okay. I mean, I think these aren't bad values, but this is not what I see advertised in
No, you're
pet.
right. And that's why, again, it's we gotta tell it for what it's worth. These are tests and they have ways to perform, and there's so many variables that go into a good performance.
Yeah, but that's really, your commentary is really, really interesting. Are you seeing any? This was early on because I'm a food guy. Early on, there was some concerns of certain liquids or foods or exercise impacting a PET CT scan, PSMA. Have those fallen by the wayside that you don't need to do that? You don't need to you don't need to have any dietary restrictions or exercise restrictions. We see that with choline actually, and there's actually for the Axemin, there's actually some mention of restrictions. How are you feeling when it comes to that and the PSMA PET right now?
I think there I think the restrictions are increasingly less apparent, but I don't know all the details about exactly the restrictions. Yeah,
Yeah.
you got to check with your individual center what they want. I don't think it's a uniform set of recommendations.
No, but I feel like those recommendations are kind of there. People seem
They're,
less.
they're, they are less important as you
Yeah.
get as you gain more experience.
That's awesome. So let's just say my PSA is undetectable. I'm doing great wherever I am in my prostate journey, but I just don't want to rely fully on PSA. Maybe I'm seeing a little increases or decreases. Some PSAs are variable, and I just go, everything looks fine. My doctor's saying you're doing fine, Mark, but I go, I just want to make sure there's no disease activity, even though I'm under therapy, let's say systemic therapy. I want to get a PET CT. Do you ever run into that where someone seems to be doing good on paper, but they want the image to tell them that they're really doing good? What say you, Dr. Raymond?
I mean, it's an anxiety based thing, and I understand. I mean, we're all going to be anxious, and the good thing about imaging and the power of imaging is you can see it right there. You know it's there or not there, and you can't argue with that most of the time.
Yeah.
So I understand that anxiety. We all have it. We're all going to have it to varying degrees. So it is much more comforting to know what you're dealing with than the unknown of not knowing. So I understand that. Whether it's validated for that, I don't think we have that answer, but I understand the anxiety, and it's reasonable to get it for that reason.
And you feel comfortable in a lot of these scenarios that what it's telling you is what it's telling you. And
Yeah,
on the,
and you know that there are limitations. If PSA is low, it's not going to be as good. You just know you have to deal with that.
Yeah, because it's weird, isn't it? I mean, we have these cutoffs like biochemical recurrence, right? We have these cutoffs of zero point 0.2, and then you have this equation for radiation that says +2 from the nadir, and you're kind of going, should we be waiting that long? Because when I look at research from Dr. Raymond, it says the higher the PSA, the more higher the chance for extra prostatic extension. So should I be relying on these equations? Maybe I should be asking for a PET CT earlier in the PSA rise.
I think it's reasonable. It's a reasonable question to answer and ask, and you have to talk about it with your urologist or radiation oncologist. And they should be guiding you as to where to get it done, who's good, and all those things. They should be, in your local area. They should be the people telling you these things.
What's better in prostate cancer screening, MRI or PSMA PET? Just screening.
MRI is simple. It's a 10-minute exam, 10 to 15-minute exam. So I would say that if you're talking about just looking at PSA
Uh,
and because
Screening.
the negative, that is, if it's totally normal, that's over 90%.
Okay. But how long's an average PET CT take a patient? How much am I dedicating my time to that?
It's radiation and it's an hour, probably
Okay.
hour of your minimum, an hour of your time, plus whole body radiation. So I wouldn't use that as a screening test. No.
Okay. How about active surveillance? Which imaging tests do you really like in active surveillance patients? When they do fall?
MRI. I go with MRI so quick, no radiation.
Okay. Are you concerned about the radiation? Some people say we're overblowing it. These are older individuals, and we're not depending on mitosis and meiosis and all this. It's more the radiation is more concerning from imaging when you are 15, 16 years old. Is there a concern?
Yeah, you're right. No, that's definitely true. It's not that. It's not that the radiation risk is so much in older patients, older than 65. But I still don't want it.
Yeah,
I don't want it. You don't know how long your lifespan is going to be. That being said, I don't know of a single case of a documented problem from repeat radiation, meaning diagnostic imaging related radiation, but I still don't want it if I can avoid it.
We were playing the game of what imaging test is best with Dr. Raman. He said prostate cancer screening, he likes MRI. Active surveillance, he likes MRI. How about rising PSA after surgery or radiation?
Depends on how fast it's rising, but I think there you're looking probably at the combination of the two, depending on what the PSA level is.
How about if I just want to make sure my no PSA after treatment means no cancer? We touched about that briefly.
I mean, if you really want to know that, then I would just do a PSMA or a PSMA PET CT or PET MRI. You want to know the ultimate test that we have right now for that? That's the test.
What about a rising PSA on hormone therapy? It's really moving.
Yeah, I mean, most of those recur probably in the prostate, so I think an MRI would be the right answer, but I think the combination would be better than either alone.
I love it.
Or I guess in that situation, just a PET CT might work. I don't know. It depends on the PSA level for that.
Your last paper, you had your name on it, I really liked this paper a lot. It was a whole group. And
I'm glad somebody read it.
No, I'm telling you, I read the whole thing. It was called Impact of PSMA PET on Prostate Cancer Management. And here you are. I circled your name on it. And this is in current treatment options in oncology 2024. And the reason I liked it is it walks you through all the places that PET CT is now used, the PSMA PET CT. And probably one of the only ones we haven't talked about together is oligometastatic disease. So oligometastatic disease and PET CT, because I know that you guys and gals are seeing these isolated spots, these oligometastatic spots that's not quite overly concerning, but then again, it's not contained. And you're excited about using PET and PSMA there.
I really like it because like in other cancers, we can treat it. And we have all sorts of little tools to treat it. It's not just radiation. We have all these ablative technologies we can use to treat it. You can even surgically resect it, maybe, but we have all these ways to treat it, and not necessarily all radiation based.
That's awesome. I mean, really, if you think about it, and the one we didn't touch on, that's for a different talk, but the only one we didn't touch on was radioligand therapy.
Yes.
But can you explain something to me, Steve, since you and I are just kind of hanging out at the bar, we're having a beer, maybe we're having some tea, maybe I'm being PC here, we're just having some herbal tea together, we're bonding, and I'm saying, okay, when you use radioligand therapy like lutetium, in these clinical trials, the Vision trial, all these things, if you light up on a PSMA, you qualify for these radioligand therapies.
You do.
But I'm leaning over to you going, but the cutoff is not a light switch. How do you know you've got enough PSMA expression that I'm actually a good candidate for any of these therapies? I mean, is this intuitive where you see a scan and go, wow, that's a lot of PSMA, or there's just enough there that would be a good candidate? I mean, where are we with deciding the cutoff?
I think the cutoff is SUV based, and I think it's the higher the better.
Does that
it's higher the better. So I can't tell you. I mean, there are some floors. I don't know the exact numbers.
Yeah.
But the low expression ones won't do as well. You know that for sure.
So what if you have a high SUV on just a couple lesions, a couple spots?
Are you saying
good about
are you
that?
saying oligomet meaning are those the only two spots, or are there other spots that don't take it up?
Both. You brought up a good point. Both situations where
exactly. If there's only two spots or three spots or five spots, treat those individually. You don't need radioligand therapy for that. If you have more than that or multiple areas, diffuse, that's where it comes. It has no competition when it's diffuse. That is more than the number you can count. If you can count them, you can probably treat them with a combination of different things. So you probably don't need it for that.
Why don't I do one
And
of them?
and in a situation where you want radioligand therapy, the more PSMA your tumor expresses, the better
Yeah.
off you are with that.
What if I do one of those? I don't know, it was a therapy trial. One of those, what they did was, I think they included the FDG PET, right?
Yeah.
Why? So if you, to explain to the audience, if your FDG PET lights up and you're not getting much activity with your PSMA, maybe you've got a neuroendocrine tumor, you got a different tumor type.
Different tumor type. Yep.
Do you rely on that? Do you do that? Do you do FDG PETs on some of these people in your department just to decide whether or not you qualify for radioligand therapy?
I think only if you are suspecting that. Yes. Only if you're, again, when things don't make sense, you got to go to a different explanation. Why do you seem to have all these widespread Mets? Why is the PSA high but everything negative? Then you got to go to FDG PET. Yep. Again,
Either way,
we're talking about less than 10% of the time, five
yes.
something percent. By the percentages, PSMA works for most of them.
But remember, less than 10% of the time. That's a lot of people who come to our site. That's a lot of people who call
It
Alex on the
is.
phone or
It
Mark.
is.
And like,
And right. And then on a case by case basis, you got to decide.
there's all this concern about PSMA PET scans. I forgot to talk about it. And you know how you excrete it in the urine? It can create these what's called halo artifacts. So the bladder kind of lights up, and that can obscure a possible cancer that's near it. Are you seeing this problem with the PSMA scans where you have these called halo artifacts where the scan is bright in an area where there could be a tumor? So you're
Yep.
not seeing the tumor? Oh,
Yeah.
but what do you do there then?
Again, the answer to me is you got to localize it really carefully. And the best way to localize really carefully is do the PET MRI.
Because again, I had not to be biased toward UCLA. A couple of people that went there that couldn't, they had a rising PSA, even though the PSMA was negative. They were MRI'd and boom, they found it.
Because,
Boom.
again, it's a mapping problem. You got to map, you just got to, again, you're going to find the shark, but you got to map the shark. Like, where the heck is the shark? Is it, where is it relative to everything else? And if you map it on the PSMA, you can map it directly on the MRI if you get the two of them together. You can approximate it if you fuse them. So, in other words, you get a PET CT at one place, MRI at another place, you fuse it. It's not quite as good, but it's
Yeah.
better than not doing it.
Well, I'm feeling good about the fact that Dr. Raman wants, after primary treatment, for example, he wants a PSA of 0.5 to feel more comfortable that he can find it. But let's say it's 0.5, 0.6, 0.7, and you still can't find where the tumor is. MRI or repeat PSMA when the PSA gets higher in general to 1 or 1.5.
You have options. You could do an Axumin. Maybe it's Axumin. Maybe it's
Okay.
an Axumin avid lesion. Maybe it's FDG avid. So you could do other tests to also see if it's one of these variants. But again,
So,
the chances of finding something is low, but not zero.
but you're feeling, I'm feeling some Michigan confidence here. I'm talking about football confidence.
Oh, yeah, I know.
I'm feeling
Let's not talk
Michigan
about UCLA.
I'm feeling Michigan confidence. Like when you hit 0.5, 0.6, you're feeling pretty good about. I know now if you can't find it, you've got these other types of scans, but you're feeling pretty good about the percentages now.
Very good. Yeah.
Okay. And now we come to the end. I'm sorry, my friend. This has been very refreshing. This is really, I appreciate how candid you've been. I appreciate the fact that you had no idea what was going to be thrown at you. I'm sure you're kind of going, what? This guy's throwing everything but the kitchen sink at me. But you're answering it all, which I love it. So now I'm going to put you in a very positive light. Dr. Raman wins $1 billion, but he can only use the $1 billion to study things. He can't use it on a trip to Iceland, which I know he wants to go on very badly.
Go back.
Go back. Sorry. So Dr. Raman wins $1 billion. And today we talked about MRI and PSMA. You can use $1 billion to do the Dr. Raman study that he will just dream of doing before he leaves this earth, whenever that would be. I want to know where he would spend that $1 billion when it came to imaging. Where should the money be put to get to the best answer in Dr. Raman's mind and his profession? Where would he spend the $1 billion?
For sure, I would spend it on understanding how to maximize the imaging that you do. So whatever you can get, what is the so in other words, I'm going to step back. I want to see what the cheapest, most widely available, and most reproducible imaging technique we can get to help the most men to then predict what their individual prostate risk is going to be. So can it predict? Can it eliminate tests? Can it eliminate all the genomic scores? Can it eliminate a biopsy? Can it predict what ultimately your own individual shark is? And so that's what I want to see. And what's going to help us get there? Will it be an imaging program? Will it be an artificial intelligence program? A combination of the imaging and some kind of blood test.
Uh-huh.
Yeah, or urine test. And that's what other people are using. You know, I gave credit to Paul Boutros earlier. They're using imaging tests, a urine test, simple urine test to predict these bad actors, bad DNA, bad proteins. Can MRI either predict those or be used with those to make a simple test that everybody can get and that we can interpret centrally, maybe with artificial intelligence, to have one unique metric for prostate cancer?
Let's
That's
say
what I'd spend $1 billion.
That's awesome. Plus, the money left over, you could theoretically do an experiment in Iceland.
I could take a budget airline there. Yeah.
So, in the next few years, if I'm getting a PI-RADS 3, I'm getting a lot of people aren't sure about the spot they're seeing, and this goes on for years and years. And I want to have my second opinion just to make sure with Dr. Raman. I'm so sorry I'm doing this to you on the very end. I'm thinking after today's talk that in a situation where it's just ambiguity, 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 and this goes on forever, that you would possibly take a look just to give a thought. Your team would.
We would, yeah. Our team consists of everybody. We have a weekly meeting with all these players, the radiation oncologists, the pathologists, urologists, and everybody else.
Yeah.
And we discuss these tough cases. Yeah.
Fabulous. You just made my day. Now let's give him. Okay, so when we're getting your address, let me show you what I'm going to ruin the surprise. Let me show you what we're going to show you in a second. What we're giving you as a gift. We give all our speakers a gift. Money's no object when we give gifts. We may miss a mortgage payment. We may not be able to send our kids to college, but as long as our speakers are happy, that's all that matters. Okay. So I thought, what does Dr. Raman not have? He probably has everything else in this world. He's got the looks, you know, he's a runner. He's at a good institution. He's a nice guy. He's got everything, but there's probably one thing he doesn't have, and it's a coffee mug with a certain saying. So can we bring that up, Peter? The coffee mug he's going to receive at his house within the next week. There it is. He's showing them it's a coffee mug that says peace, love, and radiology. Do you see that coffee mug? Peace, love, and radiology. Has anyone ever given you such a coffee mug?
I will. As long as my kids don't drop it, I will, be drinking coffee from that every day.
I knew you'd love it. Hey, I don't want to go overboard here. Like I always say, like an Oscar speech, but I've done this a long time. This is one of the most enjoyable, most interesting sessions I have ever been a part of. And you're just a gem. I really just appreciate your time and your knowledge, and thanks for everything you do. Thanks for joining us today, Steve, Dr. Raman. I really appreciate it.
Thanks, Mark. Thanks to the foundation.